Welcome to the Metabolic Link, a medical and science-focused podcast that explores the common thread of metabolism in health and disease. This is where science meets society. Welcome to the Metabolic Link podcast. I'm your host, Victoria Field. I'm so thrilled you're here with me today because we've got a great interview set up. I am the co-founder of Metabolic Health Initiative, which is the overarching organization to Metabolic Health Summit scientific conference, to this podcast right here, and to the Metabolic Initiative, which is our medical education platform dedicated exclusively to the latest science on metabolic health and therapy. If you've not checked it out yet, your first 7 days are free. Head on over to membership.metabolicinitiative.com to learn more. But today is such a great interview. We're diving into one of the most misunderstood and under-discussed topics in medicine and public health, food addiction. Joining Dr. Dominic D'Agostino, my lovely co-host, is Dr. Tro Kalayjian. And he's a board-certified internist and obesity medicine specialist who's not only helping patients overcome chronic metabolic disease, but also challenging the medical status quo with data-driven, real-world interventions. We're going to unpack his latest paper, Toward a Metabolic Health Intervention that Improves Food Addiction and Binge Eating Symptoms. This is a bold, much-needed look at how structured dietary and behavioral strategies might actually outperform some of the current standard of care and what it really means to treat food addiction like the biological, complex issue that it is. Dom digs into Dr. Tro's personal journey, the DSM-5 debate, GLP-1s, real-time biofeedback, and why ultra-processed foods might just be the new tobacco. So if you're a clinician, a med student, or someone maybe battling with food addiction yourself, this is certainly a conversation you don't want to miss. I hope you enjoy this episode.
Dr. Tro Kalayjian, it is an honor to have you here on the podcast. And I have been reviewing your paper today titled Toward a Metabolic Health Intervention that Improves Food Addiction and Binge Eating Symptoms. This topic is of great interest to our medical students, and I am really excited that you guys, were able to publish this work, and would love to hear your description of it. And as I mentioned before we got on, I have a lot of questions too for you that I hope can clarify some of the things that you looked at here.
Yeah, absolutely. Thanks for having me on. I just, we've connected at conferences, and I connected with Victoria at a conference not long ago, and love your guys' work. And so just happy to hop on here and reach all the medical students and the science geeks out there with, some of the data that we're putting together and continue to put together. And so excited, exciting times. We've put out 2 papers this year. We have 2 more coming out this year that I expect to be, really novel findings. So I think these were expected findings, the past 2 papers. We have a paper coming on Zetia and ketogenic diets, which will be an interesting paper, I think, also. And then another paper looking at cardiovascular risk calculation at the end of the year. So we are full steam ahead with the research. And I never thought I'd say this, Dom. I went into medicine 10 years ago, or 15 years ago, into medical school, just wanting to be healthy and serve my community. And I wanted to be a primary care doc. I just wanted to, help my people like my family who had suffered with obesity, diabetes, metabolic syndrome. I was 350 pounds.
Yeah.
And I never thought I would be publishing research. Never in my wildest dreams would I think that. I thought I was going to open up a shingle, serve my community, and that was it. So it's been a wild ride.
Maybe just tell people just like a brief background of your education and training, and kind of what led you down this path, I think is of high interest to our listeners here.
So I went to school at Toro in New York, medical school in Toro, New York. I did my internal medicine residency in a Yale-affiliated internal medicine program in Greenwich, Connecticut. I was chief resident there. Then I did obesity medicine board certification and did a little bit of time as sort of in academics, and then just got out, went to private practice. And I've been in private practice for over 10 years. So that's, my story. Board certified in internal medicine, board certified in obesity medicine. But honestly, the school of hard knocks is like the real, I'm FTO homozygous. Which is for the listener, one of the most common obesity genes. I'm MC4R homozygous, another known obesity gene. I have subclinical hypothyroidism, huge cause of obesity. I got to 350 pounds as a chief resident, and I had to go and teach myself nutrition to regain my health. And it wasn't that I didn't have great training. I had great training. I think everybody was taught thermodynamics all throughout the past 4 decades, and it wasn't for a lack of understanding of thermodynamics. But when I started to look into the hormonal aspects of obesity, and when I started to look at which diets perform better as an aggregate, I really started to change how I ate and lost 150 pounds, kept it off. Now we've helped over 2,000 patients lose over 100,000 pounds. So super happy about that. And we continue to publish on that, and I never thought I would.
Yeah. So do you think you actually had food addiction behaviors? Would you align with I mean, I'm sure you see that. I mean, and it's on a spectrum, right? Kind of, we all know that. And it's kind of a controversial subject because typically if you have food addiction, addiction kind of implies that, it's a drug. It's, cocaine or alcohol or other things, I guess, like sex. I guess there's some things that are not like, food is necessary. And I don't know of any other sort of thing that you could be addicted to in that DSM-5 category that like you have to eat. So it's like, you can self-restrict, or then there's abstinence maybe of certain things. And maybe we can kind of talk about that a little bit more. But I just wondered if, this is something you personally had and you saw it in your patients so much that you just felt inspired to go down this pathway.
Yeah, so I mean, this is a great question, and I think you hit the nail on the head on a topic that is beyond controversial, right? So when we're talking about food addiction, when we're talking about addiction, we're talking about the 3 C's. So if you're a med student out there, it's really, control, like a loss of control. That's one of them, right? And intense cravings, right? Like you really are drawn to that substance, and consequences, like continued use despite consequences. And these 3 C's, it's a colloquial way of sort of identifying an addiction. Now, if you look at the DSM criteria for substance use, it's impaired control, social impairment, it's affecting your life, right? You can't control it, it's affecting your life, it's causing harm. And then there's these sort of, is there a tolerance that develops? Is there a withdrawal? Is there a sort of pharmacologic component to it? And so, and then, so there's a lot of question around if food is a substance use disorder, or if it's, something like more like a behavioral addiction, like gambling or pornography or video games or whatever else, right? Shopping, right? Shopaholic. So, there's a lot of controversy here, but I think if you ask me, in my opinion, what makes food even more challenging, and you hinted at this, is you can't abstain from it. Like if I have a porn addiction, I stop porn. If I have a gambling addiction, I abstain. If it's alcohol, I abstain from alcohol. You can't exactly abstain from food. And to make it even worse with regards to food, it's a polysubstance abuse or polysubstance use, meaning, yes, sure, sugar and processed carbohydrates are uniquely addictive, but they're potentiated with processed fats, and the additives and flavors can also potentiate their effect. So it's not like there's a clear-cut boogeyman and that's the only one. There's a lot of boogeymen, and some of them are evolutionarily appropriate. Like if we weren't drawn to sugar, I mean, we may not exist as a species. If we weren't drawn to dairy fat, right? A newborn would never sort of suckle to the mammary gland of the mother, right? And we wouldn't exist. So, it's a very difficult concept, the idea of food addiction, because we need the substance to survive. It nourishes us, it helps us thrive. We can't exactly abstain from it. And yet it is so completely clear. The patient comes in to your, or they confide in you, Dom, like they know you're a researcher and they say, I'm a chocoholic or I'm a breadaholic. So they're describing this loss of control and this, the eating despite consequences, and yet we don't have a way to properly diagnose them, or at least an agreed upon way. Now, there is binge eating as a diagnosis, but it's not exactly an appropriate term in all cases. And binge eating is often characterized but there is loss of control, but there's not so much of a continued use despite sort of physical hazard, or it's usually just eating to the point of discomfort, or eating to the point of some nausea, right? It's not characterized as the same way. It's not quite an addiction. So it's a
Is that,
complicated topic.
yeah, sorry to interrupt. Is that in the DSM-5 then? Right. So, I mean, you make a strong case for food addiction being comparable to substance use disorders and things. Like my wife may say I have a caffeine addiction, and so there's harm reduction, right? So you can limit it. So maybe certain foods. But do you believe, is it, and do you believe that it should be officially recognized in the DSM-5? Because I don't think it is. And and what
Cheating
would
is.
that mean for the patients?
Yeah,
Food addiction, rather.
yeah. So binge eating is
Yeah.
already recognized by the DSM-5. Food addiction, this is very tricky. I think it should be recognized, right? At the least, it should be, under a, food-related addictive behavior, or, a substance use. I think either way, the way that the field is going, as part of the consensus that's looking to get this recognized under the WHO, it will probably be labeled as ultra processed food addiction in the near term. And there's problems with all of these terms, right? I mean, some Greek yogurts are very ultra processed, right? It doesn't necessarily mean that you can be addicted to it. So we're dealing with a complicated issue that humanity's never faced. We've never had the sort of corporate-based engineered food environment that we're currently living ever before. So, this is a unique place, and I think no matter what happens with the term food addiction, whether it's ultra processed food addiction, sugar addiction, or food addiction itself proper, yes, it should be recognized. And what does it mean? It means you can go to your doctor. They're going to be taught about it in medical school. They're going to recognize it, and they're going to be able to get you help, whether it's Overeaters Anonymous, our program, Jen Unwin's program. Vera Tarman has a program. It's to get you help, so that you can, you don't have to suffer alone. Right now, unfortunately, this is the state of medicine. Let's say we all agreed that food addiction was real. You eat despite ill health. Like I have a patient, just for the medical student that's listening to this, imagine that patient who can't say no to chocolate despite having, diabetes, on insulin, just having had an amputation, and can't say no to chocolate and bread, right? That would be somebody you should be considering having food addiction. And, continued use spells disaster for this person, whether it's a cardiac event, renal failure, going blind, another amputation. That continued use is some disorder. Now, yes, scientists don't agree if it's food addiction, ultra processed food addiction, sugar addiction, but it is clearly a eating disorder. So even if we get the DSM to say it's not otherwise specified or some sort of addictive behavior, I think we're making good ground. I want
Wait,
to pause here because you asked the question if I'm a food addict, and before I answer that, I want to like go a little back and forth.
yeah. So with food addiction, then, so if you're addicted to food or you fit the criteria for food addiction, does that, and you purge, is that distinct uh, from bulimia? And so I'm just trying to get these things kind of, and is it, if, do people who have anorexia then go, well, that's binging and purging, right? So that would be like a legitimate DSM-5, or not saying food addiction is not legitimate, but if you have food addiction, you can have food addiction without bulimia. I'm just
Yeah,
along with, is
100%.
that a correct statement? And that happened,
100%. Yeah.
okay.
So, oftentimes binge eating sort of can lead to bulimia, right? So you'll start out eating big quantities, you'll eat to the point that it hurts, and then you may end up purging. A lot of times bulimia exists completely on its own. And these are, anorexia. There's some overlap between all of these. And there's clearly distinctions with each one of them. And I think food addiction can be completely separate from all of them. I think the biggest overlap between food addiction is probably with binge eating. And I think you made a good point. The minute purging is involved, we're talking with some subtype of bulimia. And each one of these treatments is so uniquely different. They have a lot of commonalities. They're all related to our modern food environment. And Agnes Ayton did a great paper on it. I highly recommend any student to look her up. She wrote a paper called, The Blind Spot in the Western Diet. And it adequately, in my opinion, explained how this Nova-4 ultra-processed food is really at the heart of probably both, bulimia and anorexia. But that's for another time. I don't know how long you have, but this is a full topic on its own.
If you've gone to the doctor and maybe you've gone through traditional lab testing and the report keeps coming back saying everything looks fine, but deep down you know something is off, it's time to dig a little deeper. Genova Connect helps you do just that. They bring advanced at-home testing right to your door so you can look at everything from gut microbiome to mitochondrial function, hormones, nutrient status. These tests really show you how your body is actually working, not just surface metrics, and you can do it all from the comfort of your own home. And you yourself can go to the website and order those kits directly. I actually used their panels during really a time when I was going through a chronic illness, and I got so much clarity. It was such a turning point for me. It allowed for me to work with my physician. We did Metabolomics Plus test. We did a GI effects test. I was able to understand what nutrient deficiencies I was dealing with, any issues with my gut microbiome, and then rebalance and feel so much better. And I'm back to my normal healthy self. Genova Connect is offering you 15% off any of their test kits when you use the code Metabolic Link. Just head on over to gdx.net/themetaboliclink and use the code Metabolic Link at checkout. That's gdx.net/themetaboliclink and use the code Metabolic Link at checkout for 15% off. I know you're going to love their test kits just as much as I do. Now back to our episode.
Yeah, it just seems like there's a lot of credible scientists out there that will push back and say, food addiction's kind of like a catchy metaphor, and they'll say it's kind of not like, there's skeptics out there that it's like it's kind of an obvious thing that, we see it all the time that, people are addicted to food, but I guess it's just really hard to categorize it. And from what you said in the paper and just like a simple search of this category, it's upwards of about 20, is that right? 20% of people at any given point in time can have a food addiction, right? Is that inflated number, or what would the skeptics say to that?
Well, so let's talk about the skeptics, right? So,
Maybe Kevin Hall was one, I know.
well, Kevin Hall is actually a big one. So he just did a study. I mean, so let's give his viewpoint and then let's counter his viewpoint.
He said that eating too fast, but that would also kind of fall into like, I remember him saying that, and just, ultra processed, hyper palatable foods. He kind of tiptoes around the subject, but he won't classify. Yeah, he doesn't agree with that term, I guess. And
In his study, so there's two studies that I think you just mentioned. One of which was he looked at sort of weight gain using the processed versus non-processed food, and he felt that the strongest predictor of weight gain was the speed of eating.
Mm,
Right? So that would point to some binging or binge quality. He recently did a study looking into the effects of food with functional MRIs. And I think he missed the ball. I mean, he did a functional MRI. I think the time frame that he was looking at was completely inappropriate. When you're dealing with food addiction, you probably want to look at the hypoglycemic point. So if you're having a high carb load, and Regina Sinha did a lot of work on this. So if you're new to this topic of sort of functional MRIs and the impact of food on our cravings and what happens in the brain, particularly in the nucleus accumbens, that area of dopamine and addiction. Regina Sinha did work that just 20 milligram per deciliter drop in sugar was all that was needed, right, to produce activity in the addiction centers of the brain. And so if you look at his most recent study, which I think is fueling his legitimate perspective that maybe food is not addictive, I think he looked at within half an hour of eating if there was any areas of the brain that particularly lit up, and there weren't. But if you understand reactive hypoglycemia and when you should have expected that change, I think it would have been at an hour to an hour and a half. So I think, I understand the data he's looking at, I understand how that's powering his opinion, but I disagree with his opinion. I think he left the NIH because of exactly this. He was pressured to tackle food addiction. I don't feel like he felt strongly about it.
mm. Yeah, I teach a lecture in neuroscience on dopamine signaling. And it brings to mind one of the slides that I have is an obese versus a non-obese and dopaminergic activity. And I think in PET scans, and uh, an obese person has a deficiency in the D2 receptor. So just a dopamine deficiency overall. So the idea is that, I guess that brings up the question. I think what I teach, from 2008, I probably have to revise my lecture, is that there's a bidirectional kind of relationship there. So if that makes sense. So if you have obesity and uh, well, that's what I was, and low dopamine, it's sort of what's causing one or the other. And I think there's a debate about that. I think it's generally accepted, at least in neuroscience, that there's a dopamine deficiency associated with obesity, but I don't think the conversation ever gets to around this topic, which seems like an obvious topic that we should be talking about. And I think I'm glad we're talking about it now, but sort of the etiology of that food addiction, you know,
So
uh,
I've met thousands of people with obesity, thousands, many with concomitant diseases, diabetes, which every single patient is aware. I haven't met one person that said, I want to be this way, right? Not one of them, right? So I haven't met anybody that wouldn't, and to go back, you asked me a question, Tro, were you food addicted? 100% I was. And if you took validated questionnaires used for alcohol and just switched the substance to food and applied it to me, I would have been quote unquote alcoholic, right? So if you take these validated questionnaires for other substance use, switch it to food, and the Yale Food Addiction Scale does a good job of that. And I think it's a bit complicated versus other things like the Cage questionnaire used for alcohol. The Yale Food Addiction Scale is like a 15-point, scale, and it's really hard to grade. It's not so easy for the average doc to sort of just, the BED7 scale for binge eating is 7 questions. It's super easy to deploy. And that's why I think clinicians are able to wake up to this diagnosis and do something about it. But absolutely, I had I had these symptoms. I had desire to cut down, and yet my emotional response around cutting down, I would get agitated or annoyed when somebody told me to cut down, even though I would have cut off my pinky if I could, and serve it up to the gods of Weight Watchers. If I never would have gained another pound, I would have done that, right? I was desperate to lose weight, and yet I kept using the substance. And there was a lot of shame and guilt, and guilt is a big part of any addiction. Sort of shame and guilt is often, it represents this psychological distress around continued use, right? You feel shame and guilt because your emotions don't support, your subconscious doesn't support your desire to quit, right? Or stop or limit, right? And you continue so much use that it's psychologically distressing. And that shame and guilt often then the next step becomes changing your behavior to accommodate the substance. With alcohol, maybe you start to drink at an early and earlier time. Maybe you hide and sneak bottles so you avoid the judgment of others. With food, it's hiding and sneaking wrappers. It's sort of not eating in front of others and eating, a lot alone at home, waiting for all the kids to go to sleep and then, sort of binging, um, or maybe avoiding public situations because of your size and because of shame around eating or intense emotions around eating. So these are like some of the characteristics of addiction, and I absolutely had them. Now, calling it if you go back into the 90s and look at sort of tobacco use disorders, and you go to the congressional hearings, I mean, you'll see the same. I can imagine in the next 5 years, we'll have the same congressional hearings. I mean, we had every CEO of every single, tobacco company get interviewed by Ron Wyden saying that tobacco is not addictive, there's no euphoria, it doesn't fit the scientific definition of addiction. And these sort of debates happen, and we sort of laugh about that now. We look back and we say, how silly it all was. I suspect the same thing will happen with food, given that, 50, 60% of our population is now really suffering at the hands of, and probably more than that if you include heart disease and cancer. I'd say probably 70% of the population has some food-related consequence that they're dealing with. And the way that our society deals with food, I mean, you see it in the supermarket, there's more flavors, there's different flavors. It's a joke at this point.
So let me ask a question related
Yeah.
to that. So many ultra processed foods, would you say many ultra processed foods are intentionally addictive and are like on par with tobacco and alcohols, right? So I think that maybe if that is proven, and I know there's scientists that work on that thing, then that could sort of add credibility to, this thing.
Well,
I think,
I mean,
that has been
look, I'm going to
discussed.
make it super easy for you.
Yeah.
Food has been intentionally addictive. At least I have evidence since my grandma. Okay. My grandma really, 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 she really wanted us to love her food, right? She would combine carbs and fat. She would often put a little bit of salt in it, right? Just to give it flavor. She would leave out a table of a ton of different varieties so that we would keep eating. She would constantly present us this food. She would shame us if we didn't eat, right?
Mhm.
So, so we've been intending to make food amazing since the birth of humanity. Now, if the question is, have the corporations done that? Absolutely, they've done that. And if you listen to their conference calls, they say they're catering to their best customers. They say they're rolling out, additional flavors to increase sales. I mean, I don't think anybody is sitting there necessarily and plotting, to make, Dr. Tro a 375-pound doctor from being a 350-pound doctor. But, at the same token, I don't think anybody was sitting there, distilling vodka saying, I'm going to make somebody's father or brother or sister or mother alcoholic. So I think that just the mere fact that food has addictive qualities, it's a polysubstance use, right? And has, sort of potentiating combinations, right? And the fact that they are driven to sell, right? I think it's very clear, but I don't think you'll find, any like a smoking gun per se. And I'm not sure we found that with tobacco either, but I think the evidence is more and more clear that it's certainly a behavioral problem, probably a behavioral and substance abuse uh, problem as well. but it's different than other substances.
You're eating clean, you're taking all the supplements, you're doing the work, but your gut still feels off. Your energy's lagging, your skin is dull, something's just missing. That something might be cowboy colostrum. Awesome name, I know, and you're going to love what this product is all about. Colostrum is actually nature's superfood. If you've not heard of it before, it's the first milk mammals produce after giving birth, and it's literally loaded with nutrients, antibodies, proteins, all that help build a strong immune system, boost gut health, and support overall wellness. Cowboy colostrum is bringing it back in its purest form. First day, whole milk colostrum from grass-fed cows on regenerative U.S. farms, which I love. No spray dyeing, no fillers, no junk, just clean, potent nutrition that your body actually recognizes. I just started taking it and I am so excited to see the benefits, not just to my gut health, but also to my immune system. Fall is here, so we could all use a little boost, right? And also to my hair and my skin. I'm really looking forward to that. So I'm going to keep you guys updated as I go along this fun new journey. This stuff is never processed, watered down. It's small batch, ethically sourced, and third-party tested, which is so important when it comes to purity and supplements. And right now you can get 25% off your entire order. Just go to cowboycolostrum.com and use the code Metabolic Link at checkout. That's 25% off with code Metabolic Link. After you order, they'll ask you where you heard about them, and please let them know you heard about it from our show. But make sure you get your 25% off with the code Metabolic Link at cowboycolostrum.com. I know you'll enjoy it. Now back to our episode.
Let's pivot a little bit and maybe describe what TOWARD stands for, TOWARD, and sort of that acronym and kind of what that stands for. And then we'll get into sort of the methods of the study and the results.
Yeah, so that's a great question. So TOWARD, just to quickly sort of summarize it, the TOWARD intervention, and you can take this intervention and recreate it. If you're a med student, if you're a doctor, you can just take it's like, view it as a sepsis bundle, view it as as an MI bundle. We're giving you a protocol that we did so you can go sort of emulate it. It's telemedicine and texting, right? Stands for the T. It's online interactions. Don't force people to come in to see you, get dolled up. They're not going to fit in your chairs. They're going to be too embarrassed to walk up on the exam table. They're concerned that the exam table doesn't even fit them, right? So just offer online interactions. Make sure you have a W stands for, wellness coaches, right? Make sure you have a disciplinary team that includes, coaches, wellness coaches, doctors, dietitians, personal trainers. A stands for, asynchronous education. They shouldn't have to wait for the resident or the doctor or the dietitian to meet them. They should have education available to them anytime so that they can, instead of doom scrolling, they can watch the information they need to progress in their lifestyle. Real time, R stands for real-time biofeedback and remote monitoring. Use tap into iWatches, tap into CGMs, tap into ketone meters, tap into scales so that you can get to behavior at its core, get to substance use at its core, and as close to as real time as possible, right? With as minimal friction as possible. It is a very sort of shameful thing to go to your doctor and say, I'm binge eating chocolate. Nobody wants to do that, right? So if you can gently rip it out of the subconscious, if you can establish rapport and bring it to the discussion, using some technology, you're going to succeed. And D stands for diets that support, metabolic health, namely, low carb diets and intermittent fasting. Low carb doesn't necessarily have to be ketogenic. I mean, you can literally just lower sugar and processed carbohydrates. You can, leverage that depending on the degree of metabolic dysfunction to ketogenic. And intermittent fasting could be as simple as time restricting, and depending on the amount of metabolic dysfunction, leveraging that up to, 48-hour fasts if needed. A recent study showed that actually a 3 and 4 regimen, 3 days of fasting, 4 days of eating, actually decreased binge eating symptoms. So there's a lot of controversy of whether fasting increases binging. And in our In our case series that we published in 2020, that did not appear to be the case. And again, in this case, in this retrospective study, we didn't see it in a larger cohort of patients.
What was interesting, I think, is that the improvements in food addiction symptoms were independent of weight loss. So what do you think explains that? And that's a pretty novel finding, I think.
Well, I'll tell you, it's so if you look at like the some of the plots, and maybe you can bring them up somehow with editing, but most people sort of improved their food addiction symptoms. They came in with a moderate to severe amount of food addiction symptoms, and they ended up sort of in that lower range. But some people didn't improve. And the reviewers asked us, well, what's going on here? Who's skyrocketed up here? And we, myself, Laura, the clinical team, we know these patients, we know sort of what happened. And, but you can't really put this into a paper because it's sort of, we're looking at the group data and you can't explain every little finding. But that particular patient who saw a massive increase in food addiction symptoms, lost their house and lost their job. Right. So if you've been using food to cope for like literally decades and probably generations, right? And you have a high stressful moment, the calling the food and the calling of that substance is going to increase. If this was alcohol, it probably would have looked the same. The binge eating symptoms, we were more surprised by that. Like we were expecting better results from the food addiction numbers. About 46% of patients improved their food addiction symptoms. Another roughly 35 or 40% were basically neutral and the tiny amount worsened. But 81% of people improved their binge eating symptoms. And I think that's probably more biology there, right? If you say that the binging is related to, volume and the compulsion to eat, right, in a particular setting versus like a sort of psychologically and behaviorally driven process. I think that what drove the binge eating was probably the fact that they're eating. It's very difficult to binge on protein-rich, fat-rich, and foods without carbohydrates and sugar. So we weren't surprised by the binge eating symptoms. We were a bit surprised by the food addiction symptoms. 81% of patients improved their binge eating symptoms. So that was fun. And then the fact that it didn't relate to weight loss, I mean, that shocked us. We thought, the people who had the worst symptoms would have, and who had the most symptom improvement would have lost the most weight. And we don't have an explanation for it. So it's still, still a lot to learn, and the field is very novel.
Well, if you had to guess, like what's more powerful in your model, would it be dietary carbohydrate reduction or carbohydrate restriction, or real-time biofeedback or coaching and the community support, right? So there's multiple components going on here. And did you have a control where, did you control for, so I think, one of maybe the pushback is that there was no control, or maybe you guys are working on that now, just the standard of care, so how do you control, I guess, the question is, how do you control for the carbohydrate restriction? I think we're all kind of thinking, at least in the low carb camp, that's a big lever here, but there's so many other variables here, even the CGMs.
So it's tough. So I always like to sort of interpret our data in relation to the data that exists. If you look at calorie controlled studies, there's never been a portion control or calorie control study that improved binge eating or food addiction symptoms. So I think at the least, we have to say there's something here that's novel and unique. The things that are bariatric surgery. Those have been shown, and we're on par with those. Our binge eating scores are about on par with the symptoms changed with bariatric surgery. Then there's amphetamines, right, that are used for binge eating. That's pretty much the first line for binge eating. And our findings were just shy of amphetamines for binge eating symptoms. And then there's the GLP-1 medications, which are maybe 10% more effective than our program and 10% more effective than the amphetamines for binge eating and food addiction symptoms. So they just appear to really dial down the drive to eat. So, if you're doing like a systemic analysis, there have been other diets that are just of no impact, right? And so there's something here that's unique, even though we don't have a control group. And it seems to be in line with other commonly used, programs. Now, I think the diet is a lot of heavy lifting, right? Um, I'd probably say it's, 50%. I'd say having like somebody you can turn to, shame-free, guilt-free, anytime, a sponsor. Like if you look at alcohol, out of all the treatments for alcohol, I think to this day, the most effective is AA. And they're a 12-step program with sponsorship, which means they have alcohol coaches, right? And, there's some emerging therapies that may compete with AA, but in terms of the most widely adopted, they're still one of the most effective. So I think there's something to having a sponsor. There's something to knowing that you can turn to somebody who's walked the walk, walks the walk, and lives it. So I think, maybe 25% is the coaches. I would have thought much more of it was the biofeedback, right? And it is super helpful. I mean, we ask patients to take notes. They take notes in their CGMs with C spikes. We analyze them. We put in point improvements, like you struggle with pizza, go try Quest Pizza. You struggled with these cookies, go try, some dark chocolate maybe instead, right? Like we can input, or hey, we notice you're eating late at night. Can we do something to manage stress at night? Can we, get you to just after dinner grab a seltzer and go get busy? So we can do these like point like analysis, and it's really hard to do that in a systemic way. So I'm not sure that the feedback tools itself are incredibly helpful, but for the highly motivated people who have these tools, I think they are helpful. When you look at Virta's data, and they just published this using their just ketone meter and blood glucose versus CGMs, which have a lot more sort of granularity, there was no difference in A1C or outcomes. So, I've had to question if it's the biofeedback and the real-time, monitoring that's part of it. I think linking the coach with that, linking the doctor with that, I think that's the real, we also track like the app utilization, and we don't see any strong relationship between app utilization and weight loss. What we have seen is not using the app and not getting on the scale. So if somebody was using the app and somebody was getting on the scale, that doesn't really predict weight loss. But if they stop all of a sudden, that predicts weight gain. The other things that we've seen predict weight gain are, increasing variability that wasn't there before. So if somebody has an increase in blood pressure variability, in heart rate variability, or a change in heart rate variability, and the most potent predictor of future weight gain that we've seen is glycemic variability. So if they go from a nice stable blood sugar to something very erratic, we can, with our eyes closed, predict weight gain in the next 3 days and the next 2 weeks. So we're tracking all of these things, but the heavy lift is probably the diet and the coaching.
Who doesn't want more energy, a stronger metabolism, a resilient immune system, and glowing skin? I know I do. And Peak is redefining wellness with the very finest ingredients, rare, precious plants, cutting edge compounds, and formulations grounded in traditions. And their science backed botanicals, minerals, and supplements make it easy and simple to support your energy, metabolic health, immunity, and radiant skin so you can feel your best every day. Enter Peak's Pu'er teas, a living fermented superfood that goes far beyond just a cup of tea. We're packed with free, pro, and postbiotics. These teas nourish your gut, boost metabolism, and promote long-term wellness. Together, they help balance your gut flora for better digestion while delivering antioxidants that energize from within. They protect your cells and support healthy aging, which I love. So every sip leaves you feeling more vibrant and alive. Nourish your body from the inside out with living tea. When you grab the Pu'er bundle, you'll unlock 20% off for life, receive a complimentary gift, and gain access to the ancient wisdom behind their teas and wellness rituals. Discover it all at peaklife.com/metabolic link. That's PIQUELIFE.com/metabolic link to learn more. Now back to our episode.
Is there any way that you could do everything and instead of the diet, switch out a low fat diet? So, I mean, is that maybe that's kind of counter some of the education part of the Toward program, or conceivably maybe in patients to do a GLP-1 enhanced Toward program too?
Awesome. So if you came to me and said, let's do this scientifically, I would say, well, one, I would say let's back out the biofeedback, like the CGM. If you're on a low-fat diet, I'm not sure the CGM would add value. So just put the diet in, back out the CGM, and then go with it and see what happens. I would expect you'd still see weight loss from particularly if you shifted towards like a whole food plant-based diet. I think you would see some weight loss, but I think you'd run into some long-term problems. And then running a GLP arm, in our first paper, we tapered GLP-1 medications in 5 patients. We started them in 2, and it didn't matter whether we started or stopped a GLP, the weight loss was the same. So I think it shows that we actually need GLP stewardship, and we need appropriate use of GLPs, because tapering a GLP did not cause weight gain in our first paper from this year. But so this is a problem. It's really hard. We're a clinical team. We go to companies and we say, can we get your sickest patients healthy? We go to assisted living facilities and say, can we give us your sickest patients? We'll get them healthy. We'll do our best to apply evidence-based care. So, I don't know how we would control for, it's like saying we're going to give an absence of a clinic, right? I guess as a scientist, you want to tease out what component it is. And they've tried to do this with sepsis, which is how we guided our protocol, right? We looked into the literature. We said, what are all the things that reduce barriers to care, and can we bundle them, right? And can we create a clinic that reduces all these barriers? And in sepsis, they did something very similar. Early recognition, right? So we're screening binge eating right away. In sepsis, you check lactic acids right away, right? We check food addiction scores right away. We're looking at alcohol use right away, right off the bat. We're looking for that. In sepsis, you have an early intervention, right? So if the lactic acid is elevated, you're giving fluids, you're determining the source, right? And you're, giving appropriate antibiotics. In our case, we're looking for prior diet attempts, what's worked, what hasn't worked, what are the obstacles in their current daily life? What are their foods they can't live without? What are the people that trigger them? What are the workplace environments that make it difficult for them to abstain from certain foods? What times of day do they struggle? We're auditing every part of their life to determine what interventions we're going to be putting in. And in sepsis, we were doing all these, crazy central lines and central venous pressure and putting in right heart caths and causing harm, right? And so a lot of what we've done is identified, some things that don't have efficacy, and we're certainly not doing them. Phentermine, we don't prescribe, right? We're not quick to send to bariatric surgery. We'll do it as a sort of last line. We're not using, calorie counting because we feel that the data is not supportive of calorie counting approaches in obesity medicine. So we've tried to just stick to the best evidence that exists, head-to-head evidence, I should say, and implement what works. But if I was a scientist, I'd look at this and say, I don't know what to make of this, But if I'm a
Yeah.
doctor looking at this, I'm like, holy crap, you helped people lose 43 pounds that was sustained at a year while stopping GLP-1 drugs. Like, full stop. That's a novel finding. Uh,
Yeah.
so I don't know. I feel conflicted though.
Yeah. Well, I think, just taking a step back, eliminating ultra processed food and just going to low carb diet, high protein, low carb, keto diet, and GLP-1, what do? They kind of target the hedonic response, to food too. And there could be some synergy there. But um, I think that really needs to be unpacked. You did have, and maybe you touched on it, there was 1 out of 6 patients that actually got worse. And it was, good. It was kind of nice to see that, that the transparency there, that within the program, not everybody responds, and there's factors like losing your house or job or whatever. But that's 1 in 6, and there was 40 some patients, I think, or how many? 44 patients, right? In it. So uh, there's 1 in 6 patients that got worse. So what do you think happened there? And do you think that you could screen patients, that may be responders or non-responders?
You think, you know, it's a difficult the area that this cohort was, right? So we have a lot of different corporations that come to us, and this was one particular employer cohort in the South that is hit by hurricanes, that's hit by flooding,
Mhm.
and if you ask me, I think, that a lot of the symptoms are worsened in times of acute stress, and particularly systemic acute stress, right? And but there'll be follow-on studies. So I think we're going to repeat this day. We've already repeated that survey since then, and we've seen those numbers come down, and that's yet to be published. But I think it just shows how intimately related acute stress is to food addiction symptoms and all substance abuse, right? If you take any substance abuse and you add in financial distress, relationship distress, occupational distress, domestic violence or domestic distress, relocating, the symptoms are going to get worse. They're going to be called back to the substance they used, right? So I think that that's a huge factor. I mean, this is the reality that we live in. We're not going to fix everybody, by lowering carbs to 30 grams. That's not real, right? I think, and you mentioned, you know, unprocessed foods. We absolutely promote, whole foods, right? But we're also believers in harm reduction. We try to identify if a person is more likely to benefit from abstinence, meaning like just stick with real food, don't even entertain something else, or if they need harm reduction as a strategy to get into a healthier diet. So whether that means, swapping out pizza for crust pizza, or, enlightened, ice cream or Halo Top instead of Haagen-Dazs, right? We may make small shifts like this in people who are called to these foods, and it's unrealistic for them to completely abstain. So I think, all of these things make it complicated, and not everybody gets better, right? And that's why if you look at our group, we stopped GLPs in 5 patients. We started them in 2, one of which was facing an amputation, and one of which had the most severe lipedema I've ever seen. Had already lost 100 pounds and still had really large legs and, needed some further help before surgery. So yeah, I don't think at some point we run up against biology, neurochemistry, as much social support you give and as much as the food environment you can change, we can't, you know, magically improve everybody's mental health and eliminate all of their stress. It's just, I wish I could, but we can't.
do you think the toward model could be scaled nationally through like an employer wellness program and health insurance incentives? And what's it going to take to, to get this program covered by insurance, and what steps need to be taken, maybe a controlled trial for the next uh, study. But what are your thoughts on that?
So I don't have the funding to do a control trial, but we work with actuaries that have demonstrated that this approach works in metabolic disease at the corporate level. It's a one-for-one return on investment, right? So when we're selecting, we have now worked in 10 different companies, trucking companies, lumber companies, manufacturing companies, tech companies, finance companies, architectural firms, right? And fencing company, can't forget that one, a reinsurer, right? So when we work in these companies, I think patient selection is key. You offer this program to everybody. If somebody's not ready for change, which we can, determine, you put them into asynchronous education and maybe just remote monitoring, right? And you give them, a periodic coach, right? Because they're not ready for change. For those who are really ready for change and are willing to get screened, willing to get blood work done, and have a significant disease burden, right? I think an intervention like this is a great step. And in those cases, these companies that have partnered with us, they are paying for us. Their employees don't pay anything. It's free to their employees. And the reason why we've grown in these companies because there's a return. They're seeing a return, right? We're taking their sickest patients. The average BMI was 40, which is a very high risk group. Their first employee wellness study was a average A1C of 7.1. The average weight was 290 pounds. So the getting these people care, getting them healthy, one, they're happy, they're more productive. I mean, we didn't publish this yet, this is soon to be published, but the average employee coming into one of our programs comes in feeling unwell about 18 days out of the month. Out of 30 days, 18 to 20 days they feel unwell, and after 6 months, 2 days they feel unwell. I mean, if you're an employer out there and you see this, you see the fact that, with prescription, that there's no major cost and your employees get healthy, I don't need to run a clinical trial. I'd love somebody to go run a clinical trial. But I don't need to. The real world is saying, we love it. So I hope, the scientists out there can figure out exactly which components are, but in the meantime, there's too much suffering. It's just like with sepsis. They put these protocols together and they just shotgunned it. And they showed the shotgun worked better than what they were doing previously. And they still can't isolate which component is better in sepsis. Is it the quick lactic acid checking? Is it the quick fluids? Is it the quick antibiotics? Is it all of it? Is it the fact that we remove Foley catheters and central lines really quickly now? It's unclear, right? But these are things that we do as a bundle to manage this disease. And, the scientists may tease it out over the next decade, and there's been some work on that. It appears that it's early antibiotics is the big winner, but we still do all of them.
Yeah.
So I think it's going to come to fruition. It's probably the diet that does a lot of the heavy lifting and the psychosocial support, but it could be all of them.
Mhm. So just thinking about like childhood obesity and maybe the adolescent population or younger population, do you see the ability to kind of move this to a younger age range where we can sort of do an early intervention to, get people, and they might be a little bit more savvy on the sort of the digital tech and the wearables and just, the AI, the AI platforms or whatever.
You trolling me because I don't know if you know this, but me, Eric Westman, my associate doctor, Dr. Laura Buchanan, Mark Cucuzzella, Dr. Matt Calkins, and Dr. Dykman, we got together and we wrote a letter to the editor against the American Academy of Pediatrics that stated that an adolescent who wants to start a low-carb diet needs 23 blood tests and an imaging test, a DEXA scan, before they do a low-carb diet. This is their guidelines published in 2023. And just so you know, there's no blood test required or a GLP-1 drug that's recommended or bariatric surgery that's recommended, but in the specific guidelines from the AP against low-carb diets, this is the recommendation. So when they didn't publish...
And a DEXA. Why a DEXA? I mean, for the bone? Or is it like...
Yeah, I think the urinary calcium excretion, and I think in a really low... in the very low protein sort of epilepsy literature, there's some caution on the stunting, but a well-formulated ketogenic diet's not exactly that 5-to-1 fat to protein diet that is used in epilepsy. So we wrote a letter to the editor saying that this is unacceptable, and we haven't gotten a response yet. Shannon Davis, who wrote that, just as a thing, she took $200,000 from pharmaceutical companies and failed to disclose that. That's something that was not in our letter, but I just would like to put it out there on the podcast. So there's some opposition to implementing these. We are working with HHS. I mean, I know Roblox is thinking about, getting metabolic health on their platform. I know there's other game apps, looking into the Diabetes Warrior and some other game apps that are meant for, the sort of youth population that are trying to think about ways to gamify this. We do corporate challenges, so we make it a game. And, we take patients as young as 15, and, some of our most heartwarming stories, like I just, one of my 100-pound weight loss patients, just graduated, college, and I started with him in high school. And these are the types of things that are the most, like, you're preventing a lifetime of illness if you catch this early. So I hope there's an opportunity for this. There's a lot of caution with kids. Like, in my kids, I would want long-term studies, right? So, I don't know. I know a lot of times we see an epidemic and we're quick to offer a solution, but maybe we should let the scientists lead on some high quality studies before we implement, some massive systemic change. I think systemic change is needed, but I still think kids deserve good quality, studies before we relegate them to something. I'd love to see it though. I'd love to be a part of it.
Yeah, so what I know, Shibani Sethi was the senior author on this paper, and what is the thought now for moving this to the next step? Is just to apply for federal funding through foundation funding, or what's the next step here?
I think I'll talk about myself. Shibani has an amazing, clinic at Stanford. She's the director of metabolic psychiatry. She sees patients for binge eating and, food addiction all the time. So if you're out there struggling, absolutely, go to that clinic. There is a bit of a wait. Certainly our clinic can help. There's more data coming out. Jen Unwin published a multi-center study showing that a low-carb intervention had similar findings as ours. The majority had symptom improvement in food addiction, predominantly with psychosocial support and low-carb diets, and that was absent, biofeedback and text messaging and all that stuff. So I think the diet and the social support's the heavy lifting, but where does this go? That I leave to the science guys. Adrian Sotomoto was also on the paper. Shibani Sethi, they're applying for grants. We are a clinic, and we're going to continue to do clinical research. I think we've taken this in terms of the research where we can. We'll probably continue to follow these groups longitudinally, but in terms of investigative studies, it's all in your hands, though.
Yeah.
It's all in those scientists' hands, and I'm sure Shabani can run some studies, or Adrian can head up some studies and apply for grants. And hopefully, I'd love to see that. That would be great.
Yeah, I think, basic science too, that's what we do. We do basic science, clinical research, and medical education. So just teaching about, the subject, and it is of high interest. So I'm trying to get it into our medical education, courses, so just be taught about, but yeah, I want to thank you, Dr. Tro, for all the work that you're doing on this front. You're very collaborative. You prioritize not only treating patients, but education and outreach, getting on platforms and speaking about this, making people aware about it that would otherwise kind of not know. There's probably people that don't even know food addiction is a thing, right? Until they hear a podcast about it and realize that there's emerging literature, on it. So how can people learn more about this? How can they learn more about what you're doing, your clinic, and the people listening to this that may think that have an overt food addiction, or think they may have a food addiction? What resources can you steer them towards?
Yeah, we have a free app. It's called the Toward Health app. So it's an absolutely free app. There's some free material on there. There's also some paid material on there, but there's tons of free content on there. If you're somebody struggling with food addiction, if you know, relate to some of those emotional and psychological things that I talked about, get help. Call us, call our office, tor.health, text our office, email, doesn't matter. We do free programs all throughout the year. Every month we have a free program. In September, we have a free program on getting started with metabolic health. In October, we have a free program on getting started with fasting. It's live, courses with live coaches that have worked in our clinic for years. And just get help, read the literature. There's a lot of groups out there. Big shout out to the conference coming up in the UK. So if anybody wants more information about this, I'll be talking along with Georgia Eid and Jen Unwin and many more about food addiction in the UK in September. So that may be a great resource to turn to. And yeah, if you want to contact me, I'm on social media. I'm going to warn you in advance. I'm a rebel rouser, so but you can
I've seen
find me on
that.
social media. Yeah.
Yeah. Well,
So
one thing that I forgot to ask, so with food addiction, it seems to be sort of in parallel with obesity and maybe like binge eating. But it occurred to me that like food addiction is also pretty prevalent, like in the fitness community, like where you have people that are just obsessed with eating, or orthorexia, or maybe that's called. And it occurred to me that, I had come across this sort of food addiction disorder within realms of people that were in like really good shape. And I was wondering if the food addiction, the people that you treat, are all of them on the obesity scale, like heavier, or do you also see people that have food addiction that have like a normal BMI?
it's funny. It's funny you mentioned that, and I'm so glad to part with the story because back in 2019, when we published the paper on binge eating and food addiction, I get a patient that walks into our door. This is before telemedicine and all that, right? That really took off in 2019. We were doing it back then, but it was before it took off. And this guy was, 6'2", comes in just ridiculously built, could be a bodybuilder, tattooed up. And we put him on the body composition scale, and he had like a 6 or 7% body fat. And my staff is like, what is this guy doing here? And I was like, I have no idea. Apparently we work in the same gym together. We work out in the same gym, and he knew about me and whatever. Um, and great guy, great guy. We didn't come to me for medical advice, but he was like, look, do I have a problem? And he asked me this, and he goes, I can't tell you how many of my bodybuilding friends have problems with binge eating. And what you said is absolutely true. This is like a huge issue, and I think exercise bulimia is like a whole nother topic, right? Like, you maybe overeat, and then to compensate, you exercise. I think that's something I've seen in that community as well. Um, but I think food addiction, you know, for I think it's very rare to see somebody with excellent body composition having food addiction. Like I think it's very, very rare to see. Like somebody who has I mean, somebody who's really called to food. Like if you're really called to food, you're not sitting there and ripping it out of your subconscious, putting your food on a scale, like resisting all social pressure. You're not, I mean, if you know that community, it's almost a neurotic community on the other spectrum, right? Like, when these bodybuilders are cutting, they're avoiding social gatherings, their mood goes to crap, by the way. I mean, they become,
Mhm.
you
Yeah.
know, and there's, I think, a lot of mental illness in other ways, but I wouldn't say it's food addiction. I'm curious to see what you mean by that, like what you meant by you're seeing food addiction, like, like
Yeah.
what do they call it? Not the undieting, the reverse dieting. Is that what you're talking about?
Well, the thought that just popped into my head is orthorexic reverse anorexia. I don't know, that just popped into my head. Kind of like a bigger, so orthorexic, like a fixation on food, eating good food, reverse anorexia, like eating to get big, especially if like kids that, I just think about, when I was in high school or whatever, and, football coach, yeah, you need to gain weight. You need to gain weight. And it's like you have a fat. So you become fixated on food and like overeating. Not that that's causing, I don't know, I think there's probably like a mental illness there, especially with maybe in the fitness community. It would just an
Or
overfixation on the
body
food.
dysmorphia and
Yeah,
the
yeah,
bulk, I mean,
that
taking
kind
the
of thing.
bulk too far, I guess. You
Yeah,
know,
but also binging and then not purging, but like eating, just kind of maybe the addiction is not because you're eating to gain. It's almost like a chore, but then you become so restrictive that you go off of eating, clean food, and
the loss of control. Yeah,
yeah, and I
yeah.
think it's resulting from the restriction. I guess you mentioned, yeah, there's in that category, it'll be restricting for a period of time, but the restriction then is triggering the disorder. And that's why like low carb or ketogenic seems kind of counterintuitive for anorexia, but we know, Dr. Guido Frank is doing some really interesting research with low carb ketogenic diets and anorexia nervosa. So, and I don't know the status of that trial. He did share a little bit of the preliminary work, but it seems to be efficacious for people, and that's very counterintuitive to historically what we know about,
Well,
anorexia.
if you look at anorexia, and I'm glad you brought it up. I got a bit of more time, but so if you look at anorexia, it's an anxiety and control issue predominantly, right? It's almost like on the OCD side of things. It's about body dysmorphia, weight stigma, body image, lack of self-confidence, and a touch of anxiety all rolled into one. The problem is when they food restrict, what happens? They gain mental clarity for a period of time, right? When they're fasting, before the cortisol is jacked up, before they're catabolizing every bit of muscle tissue they have, they're in ketosis. They actually feel good. So they don't want to go back, right?
Mm-hmm.
So, and the problem happens not because they're in ketosis, it's prolonged ketosis with nutrient depletion, right? Their phosphate drops low, all the nutrients drop out, they're catabolizing muscle. Right. So what if we can give them the mental clarity that they're looking for while supplying their body with the needed nutrients? I think the idea of a ketogenic diet in anorexia as a life-supporting diet is a fantastic, research idea. And I can't wait to see what the literature shows. If you go to that paper that I mentioned from Agnes Satan, maybe you can put in the show notes, Western diet, it's a blind spot. Um, it talks about this sort of continuum for anorexia where they restrict, gain some clarity and control, and then it extends too far where they're actually causing insulin resistance and mitochondrial sort of dysfunction and nutrient depletion, and then they're compelled to refeed. And when they're compelled to refeed, it's without restriction, right? it's eat cake, right? And, because cake's a food group or whatever. Um, and don't restrict any food because you have a food restriction problem. So they're including essentially non-nutritive foods or modern processed food, and I'm not sure that that's actually helping, right? The underlying biology, it may help the psychology of restriction, but I don't think it's helping the underlying biology. So I'd love to see, that's a great time for a head-to-head study, refeeding with a ketogenic diet versus refeeding, cake and Milky Ways, which is, what happens now. Um, but how that relates to the bodybuilding community and the body dysmorphia, that intense anxiety that gets from low body fat. Like whenever I'm going to take pictures, I get to a lower body fat, and my anxiety goes up. Every body body fat percent I drop, my anxiety goes up. My insomnia goes up just slightly. Like something I've noticed, right? So, I'm not sure we were meant to always be very lean, right? I certainly know my biology wasn't meant to always be very lean. So, 2 years I go up, and then 2 years I'll cut back down, and then 2 years I'll go up, and then 2 years I'll cut back down.
We need a set point kind of. Yeah, I totally agree. I mean, people have set points and, and to not be obese or overweight, you have to fight that set point and a lot of it's established, kind of early on too with fat hypertrophy, but hyperplasia and just, epigenetic probably changes and things like that.
I mean, I think right at this point right now, if I could be cognizant of things that make me gain weight, it's, stress and sleeplessness. These are the number one things that make me, I haven't had processed carbohydrates or sugar in a decade. I can still gain weight. It's very hard. I could gain 30 pounds in months, in a previous life, but I can't do that now. But I can still gain weight, and it's predominantly, stress and sleeplessness. Well, either I'm, becoming more insulin resistant, or I'm subconsciously eating more, or a combination of both. All of these things play a factor on that set point. Yeah, I'm rambling. Sorry, it's like
Yeah.
six.
No, but you hit all the different things. Yeah. And we have, big levers like low carb diets, ketogenic diets, the toward approach, which hopefully there will be, more research on that. And, if needed, gastric bypass, of course, but also GLP-1s and, maybe small dosing that or micro dosing GLP-1s just to help people and then transitioning them off once you could potentially use that as a behavioral tool too. I think, maybe there's a trend to do that for some people.
Yeah, I think the GLP-1s are interesting. 50% of people generally can't tolerate it after a year. So I think we need to think about either strategies like you're mentioning to microdose, or to how to taper them off, or adjunctive treatments. But it's an interesting time to be in this field for sure.
Very.
In the obesity and food addiction space. We do have more studies coming out. I can't wait to share those with you. The Zetamide paper that hopefully that'll hit soon, and then we're looking to publish our cardiovascular risk reduction. So we're looking at that data now.
Awesome. Well, thank you, Dr. Tro, for sharing all this, and look forward to seeing you again, or maybe we can have, once you had I'm very interested in that ezetimibe or Zetia study, because that has been a topic of high interest to me as someone who has a mutation, the MPC1L1 mutation as a hyperabsorber. So I am interested in that data and what you've
I'll tell you, we ran the genes. We didn't see that a genetic. There was we did a large genetic panel, 125 genetic panel on hyperlipidemia on several of the patients that'll be in this series, and we didn't see a strong genetic, or at least known genetic. Maybe it's a polygenetic thing for the most part. Who knows?
Would you say, last question, I swear, would you say that 20 to 30% of the population are potentially hyper absorbers of cholesterol. So I heard that number thrown out, and the literature kind of vaguely suggests it with a lot of ambiguity, I think.
I mean, like, so you're talking about the ABCG8, ABCG5, and the gene you just mentioned, right? So like, what percent of the population has these genes? I don't know. I have to look that up. I got to be honest, we do the phenotypic testing. So we're doing like the camptosterol and beta-cytosterol testing. And I would say it's a hit maybe 1 out of 10 times, if I had to guess. To get geeky on everybody here, it's like, just you can run the genes, right? But you may have like one copy of a ton of genes and still absorb a ton of cholesterol. You may have like 2 copies of one gene known to absorb cholesterol. And so I don't know. My guess is 10%, I'd say.
Well, I'm super interested in that. So we'll have to have you on again when that comes out. Let me know.
Give me a couple months.
Yeah.
Thanks for having me. I appreciate
it.
you. I appreciate Victoria. And, we've had we've met a couple times. I've met your wife, and she's also so lovely. And look forward to seeing you all again. And it's just been a pleasure.
That's it for today's episode. And I just want to say a big thank you to Dr. Tro Kalayjian for really joining us and having such an open, honest, and data-driven conversation on a very complex topic. If you're interested in learning more about the Toward Health model, Dr. Tro's clinic, or any of the tools that he mentioned, check out his free Toward Health app or visit his website, which will be listed in the show description. And whether you're a provider or someone maybe who suspects they might be struggling with food addiction, there are resources and support out there. You really do not have to navigate this alone. Check out that link in our show description. And as always, if you found this conversation valuable, share it with your friends. Leave us a review. It goes such a long way in helping us spread the science on metabolic health and therapy. And before we go, I also want to mention, please be sure to check out our medical education platform. We have hundreds of videos on metabolic health and therapy, from presentations to interviews with world experts, live Q&As once per month, ebooks, you name it. It's really such a robust resource. Head on over to membership.metabolicinitiative.com to learn more. And as always, thank you for watching. Thank you for listening. I look forward to seeing you next time.
Do you love learning about metabolic health? So do we. It's why we created the Metabolic Initiative, an online educational platform providing evidence-based education on metabolic health and therapies for healthcare professionals and the general public. By joining the Metabolic Initiative, you'll gain access to hundreds of expert lectures, interviews, panel discussions, and even private episodes of the Metabolic Link. CMEs are available. Go to metabolicinitiative.com to get started. And as always, thank you for listening to the Metabolic Link.